Bismillah Rahman Rahim. Dear all participants and eminent speaker, very warm welcome to the Saudi Society for Medical Education webinar series. Uh, I'm Dr. Shazia Iqbal. I'm chairperson for Continued Professional Development Activities at Saudi Society for Medical Education Riyadh office. And we are promoting medical education in region, and we are commonly choosing those topics which are very important to enhance faculty development among our faculty members. You know, in medical education, we are encouraging our medical students to become lifelong learners. We are promoting self-directed learning, and there are different kind of pedagogical approaches as well as instructional methods which can promote problem solving, critical thinking, higher order thinking among medical schools. Reason being that medical education is ever changing domain, and you know, upcoming evidences, new biomedics technologies, they are pushing medical educators to keep on changing their learning with time, and we want to polish our medical graduates so that they become lifelong learners. So today topic is very much exciting, and topic for today webinar is early introduction of authentic teaching and learning in medical education. And I'm very much honored and delighted to introduce our eminent speaker, Professor Ibrahim Muhammad Anuwa. Very warm welcome, Prof. Ibrahim, to our webinar Sesame series. Dr. Ibrahim is Professor of Anatomy and Associate Dean for Education at Mohammed bin Rashid University of Medicine and Health Sciences in Dubai. He is medical graduate of Abu Zara in Nigeria with Masters in Medical Sciences and PhD degree from University of Sheffield, UK. He holds Masters in Medical Education from University of Dundee, UK. His professional medical education experience span over 30 years at College of Medicine, UK, in various colleges, Africa and in Middle East. He is fellow of Academy of Medical Educators and Higher Education Academy in UK. His research interests include quantitative microscopy using design-based methods in addition to medical education. He's particularly interested in exploring new ways or organizing medical curricula and innovation in learning and teaching. Very warm welcome, Prof, and over to you. I welcome all participants to this webinar, and we shall have question, answer, and discussion by end of session. So over to you, Prof.
Thank you very much, Dr. Shadia. I hope you can hear me loud and clear. Yes?
Yes, I can hear you
Right.
loud and
okay, so thank you very much for this invitation. And again, I have to thank my dear colleague, Professor Abdulmunim Al-Mardi, who have been together for quite a long time. And he kindly invited me to be part of this webinar, which I gladly accepted. So thank you very much, Abdulmunim. Now, again, thank you very much for the kind introduction. As participants have heard, my name is Ibrahim. We're very much in Dubai here as first name only. So we hardly refer to titles or surname. We like to be as sociable as possible. So feel free to just call me Ibrahim. As you can see on the topic, Abdulmunim asked me, what would you like to talk about? And I said, there are so many things that I'm interested in talking about, but one of the things that I like to do is to provoke discussion, because as most of you who are educators and facilitators of student learning are aware, the more you generate discussion and dialogue, the more things become clear. And this is not something that educators should try to shy away from. We should always be open to collaboration and discussion and dialogue, because that's the only way that we are able to understand what we're going through. So it's in that spirit that I would like to share with you my reflections. Essentially, I'm not prescribing anything. It's just raising issues so that colleagues will have a discussion, and at the end of the day, everyone is going to be wiser for it. So I intend to talk about an area that I've been involved with for quite some time, which is the early years in medical curricula. When I say early years, I really want to avoid talking about the term preclinical, because this actually should be relegated to the history books. So early years, in the sense that when our trainees come into health professions, whether it is medicine or nursing or physiotherapy or any health profession for that matter, the early years are the years where you raise their expectations, or you kill their expectations. And so it's very important to be able to capture their imagination right at the beginning, so that they don't get sort of disappointed with why they came to that health professions, whether it is medicine or nursing. So I'm going to be using the generic term. When I say medical curricula or medical education, I'm really not restricting myself to the medical school or training of doctors, but generic term, which will include all health professions. And I would just like to emphasize on the point is that I want us to be talking about teaching and learning in the early years of the medical curriculum. So I hope I have just about maybe 25 to 30 minutes, because I hope not to go beyond that, so that to allow for discussion and questions. Now, let me see if this would go right. Okay, so really my main objective of sharing with you is mainly philosophical. As I said, this will be mostly sharing my reflections, and I hope that many of us will have got the same reflection if you've been in the field for quite some time. Now, I have to provide a disclaimer at the moment. I am a basic scientist, in the sense that I am a card-carrying anatomist. So I've been teaching anatomy for all my career in health professions. So this is my first disclaimer. The second point is that, yes, I'm a basic scientist, I'm an anatomist, but I do not subscribe to the dichotomy of us versus them, basic scientists versus clinical scientists, or preclinical versus clinical, or any of those dichotomies that try to create barriers between various disciplines in the health professions. So I need to just make that disclaimer. Therefore, whatever I'm going to say, it's from that perspective. So I would like to reflect on why we teach basic science. And I would like also us as participants to reflect on that point. Why is it that we teach basic sciences in health professions curricula, medicine and others? And two, if we reflect on that, then maybe we would need to reconsider the strategies we use for facilitating student learning. And thirdly, maybe if we reflect on why we teach, we may reconsider our strategies that we use for teaching. We may actually also reimagine the tools we use to be able to find out if our learners have really learned what we have taught them. So those are really my three philosophical areas that I would like to focus on. And I am not going to be saying anything that is new. Those of us that are in the area of education and training and continuous learning would have heard this mentioned over and over again. So it's just for me to share my reflections with you, and I hope that with my reflections, there will be discussion, and there's going to be ideas that will be floating around. So the topic says early introduction to authentic teaching and learning. And I would like us to focus on the term authentic, or the word authentic. And the choice of authentic is deliberate, because one would ask, what do you mean by authentic? And if you search for the meaning of authentic, you get lots of descriptions. What authentic means is something that is genuine, something that is bona fide. In other words, when something is authentic, then it is actually and exactly what it is claimed. So if you say authentic teaching and learning, then you are talking about really the most trustworthy way by which you can teach and learn. And if you're going to extend that teaching and learning and finding out if learners have learned what was taught, in other words, you're talking about examinations and assessment, then you're talking about authentic in the context of valid, to use an education jargon. In other words, is it really what it is meant to be? So I really want us to focus on that term, or that word authentic, in following me through the discussion that we're going to be having this evening. Now, the second thing I would like to say is that you could ask, what is the background? What is it that triggered these reflections? And the first trigger for the reflection that I'm sharing with you is that sometime about 3 or 4 months back, we're having a discussion with colleagues. And as I said, I'm a basic scientist. So in the discussion among basic scientists, there was a discussion of a term OSPE, or OSPE. Now that is an acronym. For those of us that are not familiar with acronyms, OSPE stands for Objective Structured Practical Examination. And the discussion was that, is it testing a skill or is it testing clinical knowledge? And that was so my reflection, my first reflection. Okay, so we're talking about finding out how to be able to test a student learning. And we're thinking of a tool. What are we testing with that tool? Remember my reflections. Why are we teaching what we teach in medical school? Reflect on that, and then reflect on the method by which we teach, and reflect on the method by which we find out if the students have learned, in other words, to be able to assess what they have learned. So that's my first trigger of reflection. And so what I intend to do, colleagues, is I'm going to put the cart before the horse. Although we will be talking about teaching and learning, but I would like to go right at the end of teaching and learning. And obviously the end of teaching and learning is to find out if what was taught was learned. And that means having to set exams, having to assess. So I will start at the end, and then we can go back to teaching and learning and focus on whether they are authentic or not authentic. And what I would like to do is to ask a rhetorical question. Remember, I said I want us to reflect on why we teach basic sciences. So I'm asking the question again, why do we teach basic sciences to medical students? And I think the answer is very straightforward and simple. We teach basic sciences to medical students, or to nursing students, or to physiotherapy students, to be able to empower them to work safely as beginners in the health professions. We use this term generally, intern, which is the starting point of practice in health professions, where you are learning under supervision, and then you carry on training to become a specialist, and then you learn to work independently. So we teach basic sciences to health profession students, including medical students, so that we can enable them to function safely and perform the tasks of interns, and also, of course, be ready for specialist training. So fairly straightforward. And then what roles do they perform? If we are going to be able to use basic sciences to empower them, what roles do interns perform, so that we can therefore see whether what we teach them in basic sciences is what they need or not? So what roles do interns perform? And again, this is obvious. Mostly they see patients. What do they do to patients? They talk to them. They examine them. And in the process of talking to patients and examining them, they go through a process of putting what they found together to be able to think about what is going on in the patient. And of course, they keep up to date because guidelines keep changing, new knowledge keeps coming in, so they always continue to learn in the process. So essentially, the role of interns is seeing patients, talking to them, examining them, and thinking about what is going on. And the final question, what do they require to be able to perform such roles or such tasks? And again, it's very straightforward. They need some knowledge, and that knowledge is the knowledge that will translate into finding out about what is wrong with their patients. They need some skills, some clinical skills to be able to find out where is the problem, to be able to explain what is going on. And equally importantly, they need to be able to, when they encounter patients, to provide comfort, to provide hope. In other words, to be able to have a demeanor, to be able to have a certain behavior that is comforting to their patients. They need to be able to interact with their patients in the professional manner expected of an intern. So fairly straightforward. These are the requirements to be able to perform the task of an intern. Okay, then where do we start as basic scientists? How are we able to be able to empower them through our basic science? And I think we do not need to reinvent the wheel. Miller has shown this to us a long time ago, that if you are training someone for competence, think about the training process as a pyramid, in which case there is a base or a foundation. And then as you keep going up to the pyramid, the peak of the pyramid is when you have your product ready to be able to perform in that context or in that profession. So for us as basic scientists, the basic things that we do is to empower our interns with knowledge. So one of the things that we therefore need to do is to empower them with that knowledge, to make sure that we facilitate their learning, and then we check if they have got that knowledge. In basic sciences, sometimes we try to empower our learners in having to do things. And we find out if they have learned it by asking them to show us, just like we have trained them. And ultimately, what we would like them to do is, when they are in the clinical setting, they should be able to perform that role of an intern, to use whatever we have taught them, either put in their brain in form of knowledge, or what we have taught them by showing them how to do it, so that they will be able to put them together and perform the job of an intern. So this has been shown to us for a long time ago by Miller. In other words, what I'm trying to emphasize is that what we teach, there is something that we put in the brain of our students, which is called knowledge. There are things that we put in their brain, but also we would like them to show us. And there are things that we put in their brain and we would like them to show us, but we would like them to live them. We would like them to internalize that. We would like them to be able to behave in that way. Now, all this should be synthesized in a way by which we try to be able to show that in the way we teach basic science. And to be able to find out if they have learned it. Again, Miller has showed us that, well, if it is something that is in the brain, then there are tools by which you can find out if it has been learned. If it is something you taught them by showing them, and you would like them to show you, there are also tools. If you'd like to find out if they have synthesized all that you have taught them, you put them in the workplace and you observe what they do in the workplace. So this is nothing new. And this is a framework that I like to refer as going back to the basics, because that is going to help us in devising authentic teaching, authentic learning, and authentic method of finding out if our students have learned what we have taught them. Then the other important concept is that as basic scientists, we should be aware of the fact that what we teach can easily be classified into something that we put in the brain of the students, or something that we show them to do, or something that we want them to live. And again, Bloom has shown this to us, that if you're thinking about learning, there is a domain which is knowledge, there is a domain which is skill, and there is a domain which is called attitude, for lack of a better term, which we like to use, something that related to behavior. And so we need to ask ourselves, as basic scientists, are we teaching domain of knowledge? Are we teaching domain of skill? Are we teaching domain of attitude? Are we teaching a mixture of the three? Now, this is important for us so that we are very clear, because to find out if the student has learned this, there are specific tools that we need to use. For example, if we are using basic sciences to teach knowledge, then you would like them to recall that or to be able to apply that knowledge. If we're teaching them skills, we would like our trainees initially to be able to observe the skill and then possibly to try to copy and imitate. But ultimately, we would like them to be able to demonstrate it, sometimes to improve upon it, and to master that skill. And if it is some form of behavior, the top is that we would like them to be able to live that behavior. Not only to live, but to become role models, so that if somebody sees them, they will copy that behavior. So it's very important not to be confused. As basic scientists, we need to put what we teach and learn in one of these three pots so that we are clear, because the way we find out if students have learned them is specific, and we need to use specific tools. So because my main point here, as I said, my first point of reflection is that discussion we have had about OSPE. Is it a skill? Is it knowledge? So the rhetorical question I ask is, okay, what is a skill then? Because then if you know what is a skill in health professions, you will be able to say, oh, this that I am teaching or this that I am assessing is a skill. And again, AAMC, the American Association of Medical Colleges, in their recommendation for clinical skills curricula for undergraduate medical schools, they have clearly identified the characteristics of what is a skill. One, they say that for any activity to be called a skill, it needs to be demonstrable. In other words, you need to be able to demonstrate. You need to be able to show how. And with demonstration comes, it needs to be observed. Somebody needs to look at it. Somebody needs to observe it to make sure that it's done correctly. And thirdly, largely, if any activity is a skill, it requires using more than one domain of learning. In other words, not only are you going to show, but you'll be thinking as you do that. And not only you are going to be doing and thinking, but there is a pattern of behavior that you need to show as you do that. So generally, skills will require knowledge, some activity, and some behavior to be able to perform them. So then we have a yardstick. Whatever tool we are going to use to be able to assess learning, for it to be authentic in basic sciences, we need to be sure that if it's a skill, it needs to be demonstrable, observable, and should require more than one domain of learning. Remember, again, my first reflection is about aspect. Now, this is the typical item that we use generally in what we call auspice, at least in anatomy. We have a prop, which is in the form of an image that is pointing at a particular area, and then we have a number of questions, and there would be one or two or three. And what we are trying to do is first to find out, does the learner know what they're looking at? Do they know what is happening there? And will they be able to think critically about problems that would happen there? How will they present to the patient? So this is a typical example. But my question is this kind of item testing knowledge, application of knowledge, or is it testing clinical skill like we have described earlier? So that's my first item that I'm sharing with you. And I would like to propose that out of the three domains, the one that perfectly fits that item is that it's more likely to be either recall of knowledge, comprehension of knowledge, application of knowledge, or analysis of knowledge. It is unlikely to be anything else. So that's my proposal. That's another example. You have an image of what looks like an EKG, and the student is required to answer a number of questions, either to recall or to apply or to synthesize information. Is it testing application of knowledge, or is it testing knowledge? Is it testing clinical skill? And again, I would like to propose that this item, again, is testing application, analysis, or recall. Look at my third and final example. There is an instrument there, which is a tuning fork, and the question would be, for example, use this instrument to demonstrate Weber's test on this patient. Now, with this item, obviously there's something missing. In other words, it says on this patient. So there must be another component of this item, which is possibly a patient, or a mannequin, or a simulated patient. And it says demonstrate. Now, there is no way a candidate or a learner during basic science years will be able to perform in this item without having to have a patient, and without having to talk to the patient, without having to do something. Now, this is a clear example of an item that is testing not only psychomotor skill, but also it is testing something about attitude. And the student will not be able to do that until they have a background knowledge of what Weber's test is. So this is a real example of an item that, if we're going to use that in basic sciences, this is testing a clinical skill. So this is important because most people have got this varied perception of what is a clinical skill. And that's why I felt my first reflection is important, so that we have a common understanding. For example, if you're going down the street and you recognize a very famous footballer, and you say, oh, yeah, that is Ronaldo. You're using your visual senses to identify that is Ronaldo. Is that a skill? Or it is you recalling that this is the person that looks like Ronaldo. So it's important, therefore, to have a common understanding whenever we are talking about clinical skill in health professions. We're talking about a skill, we're talking about something that is psychomotor, we're talking about something that will require behavior in addition to knowledge. If it doesn't require those three, then it's unlikely to be a clinical skill. It's most likely to be something else, most likely a knowledge application and so on. Okay, so that's my first reflection that I would like to share, which is about authenticity of assessment items in basic sciences. Remember, we're talking about teaching and learning, so that's why I said that I'm going towards the end, which is talking about authentic assessment before coming back to authentic teaching and learning. Okay, so I know that I'm conscious of time. What I'm going to do now is to focus directly on the other issue, which is authentic teaching and authentic learning. And I'm just going to go to that point on my slide so that I do not bother you so much in terms of examples. Now, why this is important? Because, as I said, my reflections are on what do we do in basic sciences. Remember the big picture? We're trying to prepare these candidates to perform as interns. So in our setting, we, as basic scientists, we took practical steps. And those practical steps are that we think about collaboration rather than competition with our colleagues in the medical school. So we have a menu of courses that, from the way the courses are structured, they do not lend themselves to one particular basic science. And in most cases, they are also connected with the later areas, in other words, the clinical sciences. And we collaborate a lot in the sense that not only in teaching and learning, but in devising assessment items, we are very clear whether the assessment item is testing knowledge or is testing skill. Okay, so in summary, my message, my first message is that whenever we are thinking about authenticity and authenticity of teaching and learning, in this case, authenticity of assessment, let us keep going back to basics and ask in ourselves, is this the most efficient way of examining what we want to examine? Is it a valid way of examining what we want to examine? And finally, we really do not need to compete with our colleagues in the later years. Because if you know the history of OSP as we know it, maybe 30 to 40 years ago, it's basic science to say, okay, they have got OSCE, we should also have OSP. And the idea is not to compete, but to collaborate. So that's my first reflection that I want to share with you. My second and final reflection really is that I read a paper at the beginning of the year from these very influential people in the US. And essentially, the paper was published in Academic Medicine. In my perception, they felt that what the paper discussed is so important that they were not willing to wait until it is gone through the whole processes. Once they found that this is worthy of publishing in Academic Medicine, it was immediately published way ahead of even the online publication. And this is the paper talking about, as health professions educators, we have no choice but to transform. And they're talking about the future of medical education after the current COVID-19 pandemic. And these are very senior people, by the way, in health professions education. So my reflection is that they sort of reflected as well in the paper that whenever you have a crisis like we had with the pandemic, it should precipitate a strategic inflection point, because this was a crisis, and crises generally, they illuminate trouble, they illuminate vulnerabilities, and they open your eyes to be able to say, hey, there are some things that you need to do different. And in that way, you're going to overcome the resistance to change, complacency. In essence, what they reflected in that paper is that really, as health professions educators, the pandemic has shown us that we really have no choice but to transform, or the next time we're going to fail. And how did they come to that conclusion? They looked at how health professions has transformed itself during the pandemic. We were all locked down, we were not supposed to teach, but people through collaborative means were able to continue the pipeline of medical education. So with regards to, regardless of the disruption caused by the pandemic, a lot of collaborative work, a lot of innovative thinking enabled the continuation of medical education so that we did not miss graduation of the next batch of interns in those 2 years. And they thought there are three important aspects that enabled medical educators and the whole medical community to be able to weather the storm. One, they said that there were some core abilities that they have noticed, not only in health professions educators, but in the medical profession generally. There was an extraordinary professionalism. People utilized their knowledge to solve problems, and that is key. People are not learning just for the learning's sake, but they utilize what they have learned, they applied what they have learned to solve problems. And the problem was that, what do we do with this pandemic? How do we find a vaccine? And the third important core ability was the interprofessional teamwork across all health professions. These were the three core abilities in their view that helped the medical community to weather the storm. And now we are talking about post-pandemic medical education. And what they felt was that in our process of teaching and learning, we make it more authentic by ensuring that our teaching and learning focuses on these three abilities: professionalism, utilizing knowledge to solve problems, and improving interprofessional team working across health professions. The point I was talking about, collaboration across the years of teaching medical students. And they pinpointed some very important components. Some of them are happening. Some of them, there's a lot of resistance to them taking place. For example, they said that times have changed. We also need to change as well. And they talked about in teaching and learning, we need to make it authentic by focusing more on greater social accountability. We need to not only focus on basic science, raw anatomy, raw biochemistry, raw physiology, but humanities, the arts, because medicine is not only a science, but it is an art. They said we need to focus on more of interprofessional education, more interprofessional working. And equally importantly, we need to make sure that the transition between undergraduate medical education and graduate medical education is more streamlined, so that at the point where they are interns, they are not lost. There is a structure before they start postgraduate medical education. So what they essentially focus in that paper, which is again is my reflection on that, is that we need to focus on tasks in the way we teach and the way we make students learn. Let them learn by doing tasks, because whenever you have a task to be done in your basic science domain, the learner will be bringing in knowledge, will be bringing in skill, will be bringing in behavior in the performance of those tasks. And this is going to be my last slide for us to emphasize that it's not good enough just to be teaching knowledge for knowledge's sake. The more we integrate that knowledge in the performance of tasks, then that is the way we're able to make the learner to be able to understand and learn that at the end of the day, they will be performing tasks. And to perform a task, you need to combine not only knowledge, but skill and a form of behavior. I'm out of time. I would like to stop here. Thank you very much for the invitation. And I will be happy to answer any questions or to respond to comments. But thank you very much. I will stop here.
Thank you very much, Dr. Ibrahim, for this wonderful presentation. And it really gave us insight that what are different elements of authentic teaching and learning, and the way how we can apply it in our practice. Thank you very much. So I can see, yes, Dr. Muhammad Al-Mansour, you can unmute and can ask and start discussion.
Assalamu alaikum. Good evening, everyone. Thank you for Sesame Riyadh, Dr. Shazia, and thank you, Dr. Ibrahim, for this nice reflection that we always need to reflect back on what happened in education. I want to go from philosophical point of view, because you started your presentation from this perspective. So usually when we are talking about medicine, there are two angles that usually the philosophers of science, let's say, talking about medicine. Is it a science, or is it an art, or is it a combination between two? And this philosophical background of medicine as a profession itself, it is really a sort of complicated or let's say complex mode, and this might explain some of what you just mentioned. That shall we go in a knowledge base, or shall we go on a task base, and so on. So my point of view is, I think we need more of reflection on this. We need to go more deep in defining what we need to do in a medical school. And we need also to understand that not all those brilliant minds that we have in medical school, they are the same. We have a lot of students, they have the potential to be scientists. So if we deal with them in a vocational way, so we are squeezing them to only practicing the clinical practice, and vice versa. We need a lot of doctors to help our society. So my suggestion is, for us in GCC countries, I noticed that we don't have a lot of exit points during our MPPS program. So why don't we encourage this? Why don't we encourage the exit points after the basic science phase to have anatomist, biochemist, physiologist early on? Because you're gonna have a lot of students, they have this potential. And finally, I reviewed the Harvard Medical School pathway of their student. And it is really obvious when you just go through the diagram, you can find a lot of tracks is there helping to keep this authenticity with a diversity, rather than convert the authenticity to only one size fits all. Thank you so much.
Thank you very much. I can respond very quickly. I couldn't agree more with you, Dr. Muhammad. And really, what I would like us to do is actually to go further. So anyone who comes to medical school, thinking about doctors now, anyone who comes to medical school, I don't think they came to medical school to become an anatomist or a physiologist. They came to medical school basically to become a doctor. Now, doctors don't only treat patients, as we all know. Doctors do 100 other things. There are doctors that are educators, and they educate in basic sciences or clinical sciences. There are doctors that are excellent managers. They don't see patients, but they organize health services. There are doctors that are excellent researchers. They look at health issues and they research health problems in the lab, on the bench, in the field, and they come with solutions. So really, we need to identify the talent and guide them through that track. It's not just to let them exit after basic sciences. I think this is not it's not good enough. We need to identify their strength and lead them through that pathway. They should finish the medical training because they want to become doctors. And then they will perform all those wonderful things that doctors do, which is they treat patients, they perform research in the lab, they are educators, they are health managers, they are health planners, and they are all sorts of things. And I think maybe that's what you're alluding to. We don't really want to cut any learners learning in medical school at the end of anatomy or at the end of physiology. They should go ahead. We should encourage them. They came to become doctors, but their passion is in research. The best doctor or the best researcher is the one that has an idea of what are the patient problems. And I think I couldn't agree with you more. Thank you so much.
Thank you so much, Dr. Ibrahim, for this comments. Any other question from participants? Please feel free to ask, either write in chat box or you can unmute and can clarify if any point you have in your mind. So meanwhile, Dr. Ibrahim, it's really very a good point you highlighted regarding your reflection during COVID. So I just want to know that what was the most challenging things to apply this authentic teaching and learning during a COVID pandemic? What's your experience at your institution, especially when we look into attitude and professionalism development? So what do you think that, what was the most challenging thing for you? You can reflect on your experience and how we can authenticate those batch of students in 2 years, that whether they will be really good professionals to work as a physician. So I need your comments.
Thank you so much.
Please.
You know, we've been having this discussion right from the time the pandemic set in. And that was why I was always asking myself, okay, now we have been locked down. There was no way we are going to see the students. They are not going to come to the lab. They're not going to come to the clinical skills lab. Some of them were prevented from going to the hospital initially. It was only later, after a series of meetings, the students, some of them became convinced that, well, this is how the life is going to be. If we're going to become doctors, we're going to be on the front line. So it does not make sense, just because we are students, we should stay at home. And some students actually volunteered to work on the COVID wards at the height of the pandemic. So we had all this discussion, but from my own reflection as a basic scientist, so I asked myself, now that I'm not able to see my learners, what is my role in the discipline that I teach? That was why I said, am I teaching them something that they put in their brain? Or am I teaching them something that I want them to be able to do and show? Or am I teaching them something that I want them to be able to internalize and therefore behave. If we're able to break that down, then we'll be able to find a solution, lockdown or no lockdown. And with my own experience as a basic scientist teaching anatomy, when we were locked down, we realized that we're not going to bring them into the anatomy lab because we have, as part of anatomy learning, for them to be able to see prosections, not necessarily to dissect. We don't have time for that, but we have got prosected material so that they will be able to see them and feel them. But that is where it ends. The idea of them coming to the lab is not for them to find structures, it's for them to have this three-dimensional appreciation. So we are missing that. But is there anything by which we can help them to be able to get that three-dimensional appreciation? And the answer is yes. So we leveraged on a lot that technology had to offer, whereby we could still show them this three-dimensional appreciation, albeit in a virtual world. And that is going to make up for them having to touch the specimen in the lab. And I dare say we did that successfully because we never realized that out there are lots of resources that, frankly, now reflecting, I ask myself, then why do we take so much time taking the students to the anatomy lab and prosecting when there are things that sometimes look even better than the prosected material that we show them? So that's one of my reflections, which is that the pandemic has opened our eyes to resources that we could use that could comfortably serve as what we are doing in the lab. So that's one. And the other point is that if it is knowledge, and I need to do that in small groups, we realize that, again, there is the technology out there for us to be able to do small group teaching. We had Microsoft Teams, but we never used it. So the pandemic forced us to learn about it. And we realized there's something called breakout rooms. And then Zoom came in and we were able to do small group teaching. We acquired a software which we called LAMS, L-A-M-S, where essentially you do a lot of team-based learning, group activity sharing in a virtual setting. So the pandemic opened our eyes to doing things differently, and we've never looked back. Now that we are coming back to face-to-face teaching, we still maintained some of those activities, and it has really provided us with a form of way by which we can still keep our authenticity, but we're doing that in a different way. Now, when it comes to doing things, there's no replacement for having to do things. And the pandemic really shut us down in terms of clinical skills teaching. But with that, we really have to do it face to face, and that's what we have realized. So there is something that we can comfortably do if it is teaching something about collaboration, teaching knowledge, and if it is them doing things, we had to do that face to face. Those are my reflections as a basic scientist, because I get involved in teaching clinical skills in the simulation center. And for that, you need to be able to do that face to face.
Yeah, exactly. Thank you so much. That's really amazing that you utilized and optimized use of technology in anatomy teaching in all aspects to enhance knowledge, skills, and attitude. Any other question from participants? Please feel free to ask. If no questions, then I think it was wonderful presentation and wonderful discussion as well. So I would like to say thank you so much, Prof. Ibrahim, for joining Sesame Riyadh office. There is one question just popped up in chat box by Dr. Hamza. Is the spotter examination in anatomy can test skill? Because some colleagues think that, my opinion, it assess and consolidate knowledge. So please, can you highlight that what is spotter examination?
Thank you so much, my colleague. So as I said in the beginning, usually and frankly, I take that as a compliment. There are almost everyone in medical education is interested in anatomy. And so I take that as a compliment. And therefore, people want to know, what do you do in anatomy? My shortest answer is that if what you are testing does not require someone to observe, if what you are testing does not require the student to do something, then you're simply testing either recall of knowledge or application of knowledge. And I gave you the example that you put the student in a lab and you bring out a specimen and you put a pointer and you ask questions, then do you need to be there for the student to be able to answer that? And the answer is no, you don't need to be there. What at best, what you need to be there is the proctor to make sure that there is no untoward activity, there is no cheating going on. Other than that, you really don't need to observe what they're doing, in which case then it is testing, possibly application of knowledge, possibly recall of knowledge. But it's unlikely to be testing skill as we know it. And that's why I said we need to have a common understanding of what is the clinical skill. It needs to be demonstrable, it needs to be observable, and generally you use more than knowledge. You usually also use behavior in the interaction. So that's all I can say, Doctor. I hope that helps.
Thank you. Any other question? So I would like to thank to all participants and thank you, Prof. Ibrahim, for this wonderful talk. And we have recording. We will share recording with all participants and with Prof. You. So thank you very much, and thanks for your precious time and efforts to give Sesame Riyadh office. Thank you. Bye-bye. Good night.